Thank you, Dr. Wakefield. Boy, is she ever energetic, passionate, and the right person to be leading that agency. We are truly grateful for your participation and for all the work you do every day. Whew, it's very heartening to know that at HHS we have Dr. Wakefield, Marilyn Tavner, two individuals who are truly committed to advancing our field and that they communicate with one another. The FedTel message is an important one, that we are all working together to advance our mission. So it also gives me great pleasure to introduce our next speaker, Dr. Tom Nesbitt, who is Professor of Family Medicine and Community Medicine at the University of California at Davis. He's Associate Vice Chancellor for Strategic Technologies, and he has been the lead in telehealth, in the telehealth program at UC Davis. I met Tom many years ago from the ATA board, and he has served as a role model and a mentor for me in every way. He has an amazing program, and I am really excited that he's here to talk to us about where we've been and where we're going. Just as Dr. Wakefield said, where we're going is our focus. So please welcome Dr. Nesbitt.
Okay, well, good morning. I'm going to cover a lot of material in a very short period of time. I want to first say, I do a lot of CME talk, so I want to say I have no conflicts. I'm not on any boards. I don't get paid to speak, and I don't own stock. I'm going to try and get through a lot of material, as I said, very quickly. I can only touch on some of these things very briefly because of the amount of material. So if your particular paper or project doesn't get covered, I apologize. What I want to do is cover definitions. I want to talk about the rationale. I want to talk about telehealth in the setting of the home, the clinic, and the hospital. And I put in radiology, pathology, and pharmacy in between the clinic and the hospital because they relate to both. And then a quick summary. So in terms of definitions, the Institute of Medicine defines telemedicine as the use of electronic information and communication technology to provide and support health care when distance separates participants. Now, there has been some interchanging of the terms telehealth and telemedicine. Some people use one versus the other. Both of these describe the use of these technologies to improve patients' health status. Telemedicine has typically been used more to describe direct clinical services, where telehealth has been used to define a broader scope of services, including things like patient education and other related services that still improve health. So what's the rationale for this? Well, probably one of the landmark publications in the last couple of decades has been Crossing the Quality Chasm. And in that, the committee said information technology must play a central role in the redesign of the healthcare system if we want a substantial improvement in quality. And I think it could be argued that nowhere is this more true than in rural areas and in rural communities. Keep in mind that at the same time we're talking about this, that there continues to be an increase in medical knowledge. The NIH and the National Academy, I mean, there is new knowledge and new science being developed all the time. And when some people have access to that new knowledge and expertise and other people don't have access, then the disparities grow in a relative way. And the theme here is that advances in telecommunication and information technology can help overcome some of these disparities by redistributing that knowledge and expertise to where and when it's needed. So let's jump right into talking about care in the home and in the community. So there has been a long history of talking about providing care into the home. And there's an article in The Lancet in 1879 that talked about the telephone to reduce unnecessary physician visits, and there's even a report of listening to a child with croup. monitoring, home monitoring, which we're going to talk about, which has a longer history than this, but certainly got developed with NASA in the Mercury space program, where they began doing physiologic monitoring over a distance, and they expanded that with the space technology applied to rural Papago Advanced Healthcare, the StarPac project, where they further developed this technology in a pilot with the Papago Indians. Back in 1925, this was an article published in Science and Innovation magazine where they envisioned video to the home, and they even envisioned a device that would allow you to examine a patient over distance. And so they were thinking that this would occur in the next 50 years, and we're not that far off. But we certainly have a big need, and the biggest need, I think, in the home and in the community relates to chronic disease, which, as Mary said, affects rural areas possibly more than anywhere else. But there's 100 million Americans with chronic disease, accounts for about 75% of our healthcare expenditures, and traditionally we've used an episodic office-based model for managing chronic disease rather than a care management model that uses frequent patient contact and regular physiologic measurement. The VA, and you're going to hear about this more, and I'm just going to touch on this, the VA figured this out over a decade ago that this wasn't the best way to manage chronic disease, and so they developed a program with education, monitoring, and feedback at home and personalized remote care management from a disease management support team. And their data goes back even further than this, but in their study that they published in 2005, they showed reductions in hospitalizations and reduction in bed days. They also showed some improvement in some physiologic measures. They also showed better adherence for medication. In a later report of 17,000 people, they confirmed these reductions in bed days, reductions in admissions, and they had very high satisfaction as well as relatively low per annum costs. This report just came out in May of this year from NEHI, where they studied these technologies, and in this report, again, they confirm reductions in emergency department visits, hospitalizations, hospital readmissions, hospital length of stay, and overall costs. Now I'm going to just touch on a couple of specific areas, and again, I have thousands of articles that I can share with you if you want, but I'll just touch on a couple of specific areas. In the area of hypertension, this is a study published in The Lancet in 2010 that showed the addition of monitoring at home did in fact improve the management of hypertension. This is a meta-analysis done on chronic congestive heart failure of 21 studies indicating that home monitoring did reduce mortality compared to usual care. And in diabetes, another meta-analysis that did show that home telemedicine had a positive effect on hemoglobin A1Cs. And they also showed that that home telemedicine or home telehealth helps to reduce the number of patients hospitalized and hospitalizations. But in both these meta-analyses, they acknowledge the fact that we do need more higher quality studies in these areas. So where are we going in this area? Well, I think we are, the devices that were being used in the VA study, I think we're going to see more of those, and we are seeing more of those produced. A number of different companies are producing these devices. Some are going to tablet-based, and some are going to laptop-based systems. These have peripherals that connect to them. The other thing, and again, I'm trying to avoid brand names and those kinds of things, so I'm using this out of the Berkeley School of Engineering, out of the Citrus program. We're going to see smaller devices for physiologic monitoring. This is a very small device that combines an accelerometer, ECG, stethoscope, myography, and other functions. It has Bluetooth to a cell phone or a PC, and it has a fair amount of storage with it. And because we're able to use make these devices smaller, we can put them into different form factors. So different form factors like a watch or like a ring that measures blood pressure, heart rate, an earring that does pulse oximetry, and those kinds of things. So I think we're going to see these kinds of devices put out. So what are our challenges and opportunities for the future in the area of home health? Well, I think one of the issues is patient preferences and acceptability of telehealth. A lot of studies, and there's, many of them that have been done, a lot of pilots show attrition of people using these technologies after the pilot ends. And so there is a lot of attrition from these, and why is that? And it's, have we figured out what kinds of devices people want to use? How much intrusion in people's lives are they willing to accept? There's a device now that goes on your chest and will measure whether you actually swallow your pill or not. And do people really want that? How do we better involve patients and their families safely in care? And what's their role? How do we use off-the-shelf devices like mobile phones, gaming systems, other things like that we need to be able to figure out how to use? And what is the quality that we have to use of a mobile phone if we're going to do that? And probably these last two may be the most important. How do we manage and transform all the data that's flowing in from all these devices and turn that data into information that's actionable by a clinician? A lot of physicians out there don't have disease management teams that they can use to manage the data. So how does the small doctor's office in Nebraska or North Dakota use the data in a way? Because this undifferentiated flow of data is somewhat threatening. And what policy changes and supports are needed to allow rural populations to be able to use these models of care? Again, because although big systems can have disease management nurses, etc., how does the average clinician use that? Let's switch to office-based care. Well, the inventor of the ECG published a paper in 2006 already talking about the telecardiogram. From clinics on ships to clinics to shore, they've been using the radio, and the radio's been used in other places in Alaska for many decades. And probably one of the most famous uses of television is the 1968 use of it between Massachusetts General Hospital and Logan Airport. Going up a little bit further in time is the use of other kinds of telemedicine. And in Alaska, they've really been a model for the development of telemedicine. And I show this picture for a couple of reasons. One, this is a community health aid that's doing otoscopy, and they added audiometry to this. But again, in this population, they have a very high rate of middle ear disease. And the information can be sent down to Anchorage or Fairbanks where specialists are, and they can make a determination whether a patient's need to travel down there for more definitive treatment. But again, this has been done for decades in Alaska. Today, we think of telemedicine as these office-based telemedicine as these flat-screen, high-definition units, and there's a lot of them out there. There's a lot of these units out there, all of which don't talk to each other, some of which use proprietary communication standards. So if we want this to be as ubiquitous as the telephone, we're going to need to think about things like communication standards. They have peripheral devices that can aid in physical examination of the patient. And something that's been a great advance is the use of more store and forward or asynchronous technologies. I'm going to talk about dermatology in a minute, which has been a very successful use of asynchronous telemedicine. But in terms of ophthalmology and optometry, the use of these non-mydriatic cameras to screen diabetics, this has really increased the screening rates of diabetics who need to have retinal screening. And these are, again, non-mydriatic cameras where you don't have to dilate the eye, and they've been quite successful. Teledentistry, and I thank Paul Glassman for some slides. I wish I could use all of them, but teledentistry has been used where you can use this in combination with X-rays and this exam, these examination tools, where you can examine patients and do a very good dental exam between a dental hygienist and a general dentist, or a general dentist and a specialty dentist. And again, this can really improve access to dental services. So I want to just touch on a couple of office-based areas, and I'm sorry I can't, because literally every office-based area has been studied, but I'm going to hit mainly on dermatology and psychiatry, two of the biggest. So there have been studies going back into the 90s showing, very good agreement between in-person care and teledermatology. Just in June of this year, there was a study published on patient satisfaction. There's been lots of patient satisfaction studies over the years, but this is a new one showing that patients have a high satisfaction rate. And the third one of these studies is important because some people worry that if you see a patient via teledermatology and you diagnose a condition that needs definitive surgery or something, those patients will get delayed into that care. But this is a study that, at least in this population, this didn't happen. And the last one of these is from April Armstrong, who looked at why some dermatologists don't do this. If this is so wonderful, why isn't everybody doing this? And there were a number of reasons, issues about malpractice and training, but a lot of this had to do with reimbursement, either not knowing about reimbursement, how to get reimbursed, or the level of reimbursement. And you're going to hear about some of this in our reimbursement panel about some of the barriers, so I'll just tease you with that. In mental health, there have been studies done, Elford in 2000 and Ruskin in 98, and then again in 2007, showing good agreement between in-person diagnosis and treatment plans and when they're done in person versus telemedicine. And again, high satisfaction rates, even among parents of kids with psychiatric illness. Whoops. I wanted to show this study just to give you some idea of some peripheral benefits. This is a study we did in 7 rural communities, and we looked at the opinion of healthcare in that rural community prior to telemedicine being introduced, and then 19 months later looking at it after telemedicine was introduced in the community. And it showed that rural communities had higher, community members that knew about telemedicine had a higher opinion of healthcare once they knew about telemedicine in the community, and people with a higher opinion were less likely to leave the community. So where are we going in this area? I think that the equipment's going to change. This is an otoscope that connects to an iPhone, and you can get a good picture. You can show the patient. You can send it to the otolaryngologist. And ask, is that tube in the right place? I think we're going to see more integration of telemedicine with electronic health records. A lot of the big electronic health record companies are already doing this. You'll see integration of telemedicine decision support and the EHR. So in office-based care, what are the challenges and opportunities? So how do we use non-traditional providers like in Alaska or like dental hygienists rather than the traditional providers? And I know this gets into scope of practice issues, and that's a very touchy subject, but again, we need to think about that. How do we use new models that build community clinical expertise using these technologies? And you're going to hear about some of those when we talk about the Project Echo. Can we improve the interfaces, HD, 3D? How about less costly equipment like handheld, such as a handheld device like I showed you with the otoscope? We need to continue to develop evidence-based standards for care, but how can these reimbursement models support telemedicine to rural and remote communities? There, again, in that dermatology study, there's a lot of challenges for a lot of specialists, even getting the patients in that want to see them in person. Why should they then add providing care over distance? And we need to think about how the reimbursement models work. I'm going to talk about radiology, pathology, and pharmacology very quickly. So radiology's been around, teleradiology's been around for a long time. I found an article from 1948 from Philadelphia to Chester County Hospital. But teleradiology's clearly the most common form of telemedicine. We used to do it with camera on a stick or digitized films, passing the film through a digitizer. And now we use direct digital capture in most radiology and PACS systems. And that's allowed for the development of Nighthawk services. If you get imaged, tonight in a hospital in this area, the person reading that image might be in Australia. So again, it's used quite commonly. It's the way radiology is done. But one thing the radiologists have done, which I think was very important, is they've really promoted a standard that they use for transmitting and storing data. And they've really promoted the DICOM standard, which is used in other areas of medicine as well, but they've been very good about it. These are just some images using the DICOM standard. Going back to the late 90s, there were studies that already showed that using teleradiology reduces transports for head injuries out of rural areas. Also a study done in '98 showed that when a radiologist was available to rural emergency rooms, that it changed the diagnosis 30% of the time, and the treatment plans about a quarter of the time. Pathology, a report from 1989 showing it used in northern Norway for pathology. It's less common than radiology, but digitizing pathology slides is becoming much more common. Now, these are very large files because you have to have color and you have to be able to do different magnifications. And a lot of people were concerned about moving these very big files across firewalls, but now there's a number of models being developed where the image sits up in the cloud and you only have to view it. So it's sitting on a server somewhere else and you can view it over distance without having to move these big files across firewalls. These are just examples of some digitizers for slides. Certainly used for a second opinion on critical lesions, which is what this study was about. And this is a study that demonstrated that a specialist pathologist doing it via telemedicine is better than a staff pathologist there on site, that in 74% of cases the diagnosis was more precisely done, and in 18% it had a major positive impact, because these were sort of just-in-time pathology cases. These are two studies, one in breast cancer and one in neuropathology, just showing that the histopathology can be done very, very accurately using telepathology. Pharmacy. Pharmacy's been done over distance for a long time. Any healthcare professionals in the audience know how often you call the pharmacist. I mean, first day of your internship, you call and say, I'm supposed to give this guy this medication, and he's got renal failure. How much should I reduce the dose, etc.? But there's some well-known telepharmacy projects, as Mary mentioned, in North Dakota, as well as in eastern Washington. Now telepharmacy is facilitated by computerized physician order entry and remote review, and even remote dispensing. So you can dispense medications using Pyxis machines and others from a distance. You combine that with video, being able to review medications, and a video consultation with a patient. That allows the whole thing, the whole pharmacy visit, to be done over distance. So this is a paper published again this year, just demonstrating that on 47 cancer patients, they were able to save 27,000 miles of travel because of telepharmacy. And as many of you know, pharmacy is a critical part of the care of cancer patients for mixing and administering chemotherapy. This is an interesting study done out of North Dakota, and this showed that this is a fairly large study that was done. And what was interesting about this study is they showed the error rates in telepharmacy and in-person pharmacy, and both those rates were far below, in this study, the national rate. Telepharmacy was slightly higher, but again, it may be the difference between no pharmacist and a telepharmacist. And this, I had to put this in because we just published this, and this was hospital-based pharmacy. And this was a study we did with six rural California hospitals. And rural hospitals have difficulty affording to have 24-hour pharmacists. So when medications are ordered and delivered to patients in the hospital at night, there may not be pharmacy review. What we did is we used telepharmacy and found in about 19% of patients that there was one or more medication errors that was picked up by the remote pharmacist. Home stretch. Hospital-based telemedicine. So probably one of the most famous uses of hospital-based telemedicine they started developing in the late 50s, early 60s, was a closed-circuit television link between the Nebraska Psychiatric Institute and Norfolk State Hospital, where they did psychiatric consultations. I also was really trying to find something on skilled nursing facilities and was able to find this study from the Boston City Hospital with a really low-tech system that actually showed some positive results. But hospital-based telemedicine in the hospital versus the nursing facility, but hospital-based medicine is really growing in two areas. The two areas it's growing in is in stroke and in ICU care. And I want to talk about stroke first. So this is a couple of reports, and the first one was a study published in The Lancet by Brett Meyer. The second one was probably significantly changed things, and that was the American Stroke Association publication in Stroke that said that stroke exams can be done over distance in a very quality way as long as you have good imaging, but also they recommended the use of telestroke in hospitals that accept stroke patients that don't have stroke neurologists available. So again, very important. Now, in the inpatient setting and in the skilled nursing facility setting, there are a number of devices. You can drive robots around, or you can have the nurse put the unit in the room and see patients. And I think in skilled nursing facilities, I think this is really low-hanging fruit. There's a number of studies that show the number of avoidable visits to emergency departments for skilled nursing patients. And I think particularly in rural areas, some skilled nursing facilities in rural areas exist in communities where they don't even have physicians, and getting physicians there urgently can be a challenge. Nihai did this recent look at this, and again, just published in May of this year, they showed strong evidence of clinical benefit and savings with increased use of telehealth in nursing homes. This is a paper that was published in 2010 looking at geropsychiatric care via telepsychiatry. And basically it showed that people were, families, nursing home personnel were very positive about the use of this. And again, it provided care that was very acceptable to patient families and nursing home personnel. So I want to talk about critical care for a minute, and you're going to get a talk on this, so I'm just going to breeze through a couple of things very quickly because we are going to talk about critical care later. This is probably bordering on 10% of beds now that are covered by tele-ICU, and the components of tele-ICU differ, but the most robust model of tele-ICU includes intensivists from a command center with nurses and other personnel, monitoring systems that track patient status, smart alarms with full audio video, and then protocols that are wrapped around those that help manage patients. The literature in this has been mixed, and even since I put this talk together, there's another article that's come out showing that it's mixed. But this was an article by Thomas. You'll hear about this again in a minute, but this didn't show overall improvement, but it did show some benefit for the sickest patients in terms of survival. This is Lilly's study that was published last year in JAMA, which they did show improvement in mortality, reduced hospital length of stay, as well as change in best practices. And this is a study this is a meta-analysis that concluded that, there probably is lower mortality and reductions in ICU and hospital length of stay. But they did acknowledge that we're not really sure what configuration and what are the elements that make the difference in this. And this is a paper that Jim Marson did, and this is a consultation-only model for pediatric critical care. And what Jim showed in this paper was that it significantly reduced transport costs from rural areas, which goes without saying, but there was cost savings because of that. And there's also financial benefit. As many of the adult ICU studies have shown, there's financial benefit to hospitals because they keep the patient and the revenue in these hospitals rather than sending them to a large tertiary center. So where are we going? Well, I tried to come up with something space age for the end of this. Telesurgery. There's a famous case that was done, the Lindbergh operation that was done in 2001, September 7th, 2001, from New York to Strasbourg, France. And they did this surgery, and it was a cholecystectomy they did over distance. We're waiting around for, the patient to do well, and 4 days later, unfortunately, there wasn't anything else in the press but September 11th. But it has been done. There are pilots being done in Canada. And telesurgery, if you can operate from one room to another, you can operate over hundreds of miles, and certainly get great displays, and you can operate very well. I've said to people, I don't want to be the first one, but it can work extremely well and project evidence or project expertise forward, particularly technical expertise. So finally, what are the challenges and opportunities for the future? Well, I think in hospital-based care, I think one thing we have to figure out is what are the elements of tele-ICU that make the difference, and how can they be tailored to smaller hospitals? It's often very difficult for hospitals with 2 or 3 ICU beds to bring this in, and I think people are beginning to work on models that will incorporate that. As for the development, a lot of the expansion has been in for-profit companies coming into stroke care, into ICU care, etc. And those models, quite not unexpectedly, are with hospitals that can afford it. So how can we build incentives in to expand those to rural communities so either private or public institutions can afford to do this in rural communities? Telemedicine and skilled nursing facilities, are there enough incentives? I think there are as we start not paying for readmissions. And I think we will see the increase in telementoring and telerobotic surgery as we try and project technical skills forward. So in summary, I think advanced telecommunication and information technology really do have a role to play in transforming the healthcare system. I think evidence-based models facilitated by these technologies can improve access and quality across the geographic and economic spectrum. To date, though, we've been attempting to layer these technologies on to a healthcare system that don't have the necessary incentives. And so I was going to say a broken healthcare system. You can be your own judge, but we've been attempting to just sort of layer the technology on to something that hasn't been working that well in the first place. I think with the ACA and other policy changes, it can help facilitate this transformation. I do think more research is required to develop appropriate quality standards in all these areas of care. Thank you. Maybe a minute for a question or two. I went long. If not, great.